Let me go ahead and introduce you here. We have Dr. Yaya Samadi here from the Child and Adolescent Psychiatry Fellowship at UT Tyler Health Science Center. Dr. Samadi has begun his fellowship this last year with us and is under the supervision of Dr. Taya Johnson here. Dr. Johnson is one of our child and adolescent psychiatrists here with the CPAN team. And if you have contacted CPAN for consultations in the past, you may very well have spoken with Dr. Johnson. We're excited for Dr. Samadi to join us today and to share in this very important topic, and looking forward to what he has to share with us. At the end of the session, we will have time for Q&A. If you would like to add your Q&A questions into the chat, you are certainly welcome to do that. And we will get to those Q&A questions at the end. So, Dr. Samadi, I'm going to hand this over to you. Thank you.
Thank you so much. Thank you for this introduction. So this meeting will introduce the staff working in primary care settings to the current epidemiology of youth suicide in the United States and evidence-based approaches to screening, assessment, and treatment planning for youth presenting with suicidal ideation. So we will see how to screen in a simple, comprehensive, effective, and most importantly, less painful way for both primary care providers and adolescents. Also, it will address the need for timely and effective consultation with mental health professionals to facilitate emergency psychiatric care for youth in greatest need, and timely support and referral for those with less acute presentation. It may also useful for psychiatric forces who might be integrated into primary care sites or providing support and consultation to nurses and other PCPs from emergency psychiatric settings. So these are the objectives for this presentation. And I would like to start with this graph. It shows how the rates of pediatric death by suicide in the United States increased 33% from the year 2000 to 2017, with increases among both males and females from age 10 to 14. Another table here show why do we need to talk about suicide? Because it is the second leading cause of death in adolescents. This is an epidemic, and as such, we want to keep partnering with you, help address. Although all youth who present with suicidal ideation should ideally have immediate access to mental health professionals, this is not always possible because over 100 million US residents live in mental health professional shortage areas. And with declining numbers of practicing psychiatrists. And responding to these shortages, the American Academy of Pediatrics have recommended that primary care providers screen and assess for suicidal ideation and learn to manage mild to moderate mental health conditions to make more effective linkages to limited specialized care. So let us proceed for more scary numbers, and never forget that it's okay to say, it's okay to ask, and it is life-saving to ask and assess. Approximately half of those with behavioral health problems or psychiatric concerns did not see a behavioral health professional, which often leaves nurses and other PCPs to cover this gap in care. In fact, individuals of all ages who died by suicide were more likely to have seen their PCP in the last 30 days before committing suicide. The figures reported sadness, hopelessness, depression, suicidal ideation, suicidal behaviors have doubled another time from the year 2017 to 2021. In 2017, 1 out of 3 of high school students reported a persistent feeling of sadness or hopelessness. And 1 out of 6 reports seriously considering suicide. But in 2021, 1 out of 3 of the high school students report seriously considering suicide, and more than half reported sadness and depression symptoms. And 1 out of 4 reported suicidal plans. Females considered suicide at almost double the rates of male counterparts, attempted at higher rates, and required more medical attention for attempts. However, males died by suicide at much higher rates than females. And although rates of death by suicide for males are much higher than for females in adolescence, it is important to also view these estimates in the context of greater trends for the communities we serve. For example, a review of deaths by suicide in the African American adolescents from 2000 to 2017 found that rates for females increased by around 200%, while rates for males increased 60%. So it's important to consider the suicidal trends in its cultural and social context as well. Let us take a closer look at those adolescents who died by suicide. In the National Violent Death Reporting System data analysis of all individuals in the database who died by suicide in 2015, and for whom toxicology tests were performed, found that around 80% of those with and around 70% of those without known mental health conditions tested positive for at least one illicit substance, most commonly the alcohol. Adolescents and young adults aged 20 to 24 comprised around 14% of the total database. Recent or upcoming crises and physical health problems were noted for those with or without prior mental health diagnoses. School problems were noted among youth 10 to 18. And in the same study, 75% of individuals with mental health condition have been diagnosed with depression, followed in frequency by anxiety, 60%, the bipolar disorder, 15%, schizophrenia, around 5.4%, and the post-traumatic stress disorder around 4.5%. Again, in 2021, I just want to repeat that 1 out of 3 of high school students report seriously considering suicide, and more than half reported sadness and depression, and 1 out of 4 reported suicidal plans. So other factors contributing to increasing risk in adolescent populations committing suicide include social media consumption, increased in bullying and cyberbullying, bullying and family rejection of the LGBT youth, history of physical or sexual abuse, the history of adoption, and there is the potential glamorization or romanticizing of suicide in media, sometimes hybridization of suicide with transmigration, colorful spiritual experiences, such as the Netflix series, The 13 Reasons Why, from 2017 to 2020, and the persistent and bidirectional impact of stigmatization about suicide. So we have two sides here, the stigmatization side and the glamorization side. Both of them are contributing factors to increasing the risk in adolescent population. There is no one cause for the spike in suicidal rates among this population. It's an amalgamation of factors that play out differently in each individual. The most important elements to focus on is the assessment of the adolescent's cognitive and socio-emotional capacity and the current context of his suicide, and how a treatment plan will most safely and effectively serve their unique needs. We may see the high risk for suicide in adolescents from the developmental lens. And one of the key explanations for these trends in adolescents' risk of suicide is that there is a distinct discrepancy in the developmental capacity of adolescents to process stress and to cope effectively, specifically surrounding deficits in abstract thought. Uh, Adolescents are cognitively and acutely able to recognize life stressors and act on these emotions, like, for example, sadness, desperation, hopelessness, helplessness, worthlessness, etc., but often without fully developed impulse control or long-term planning ability. And this is putting them at the increased risk of generating suicide as a possible solution and having the ability to create and carry out plans for suicide. The timing of puberty also plays a significant role. Girls who are found to mature earlier than peers are at increased risk for depression, substance use, and early sexual behavior. And boys with asynchronous pubertal development may also have more psychopathology. Uh, the American Academy of Pediatrics guidelines recommended that all pediatric patients be screened for suicidal thought behavior. And there is an evidence suggesting that these adolescents with suicidal ideation carry a greater lifetime risk for suicide attempts. Thus, early screening and intervention is a key element in a public mental health approach to suicide. The specific APA recommendations are to use formal depression screen yearly and to also ask about mood disorders, bullying, victimization, or preparation, drug and alcohol use, sexual orientation, gender identity, and other factors that might increase risk of sexual thought behavior. The American Psychiatric Association and the American Academy of Child Adolescent Psychiatry, on the other hand, recommended that screening begin with a detailed history to evaluate the past psychiatric conditions, family history of suicide, personal history, relationship with suicide, school disturbances, and the patient's risk and protective factors, in addition to detailed psychosocial history and trauma, which is always missed. Most specifically, it is important to screen for active mood disorder as they are a primary risk factor in adolescents. When there is a history of suicidal thought behavior, it is important to know that the patient carries a heightened risk for additional suicidal thought behaviors for at least 1 year after the acute episode. And it is important to know that screening for suicidal risk does not increase the frequency of suicidal thoughts in adolescents. One of the high recommended screens is the SSHADESS, endorsed by the AAP. The SSHADESS explores risk and protective factors via eight key domains, including strength, school, home, activities, drug and substance use, the axis of emotions, eating, depression, then sexuality and safety. And we can see that the order of assessment is from the easiest one to the hardest one. And embedded in these domains, the line of questioning touches some important variables that are associated with increased risk for suicide, including previous suicidal attempts or self-harm history, co-occurring psychiatric conditions like depression, anxiety, substance use, sexual and gender minority status, current or historic bullying or sexual abuse, and insomnia, among others. It is a screening for strength, well-being, and risks at the same time. So, for example, when we are assessed the strength, we can ask questions like, "What do you like doing? How would you describe yourself? Tell me what you are most proud of." When we are assessing the school, what do you enjoy most about the school? What do you enjoy least about the school? How many days have you missed? How are your grades? Any difference from last year? Do you feel like you are doing your best at school? And if no, why not? What's going in the way? Then the assessment of the home, we may ask us questions like, who do you live with? Any changes in the family? Could you talk with anyone in the family? Then we assess the activities. Are your friends treating you well? Do you have any close friends? Uh, are you still involved in the activities you were doing last year? What kind of things do you do just for fun? Uh, Moving toward the drugs and substance use, here the questions are a little bit subtle, such as, do any of your friends talk about smoking cigarettes, vaping, taking drugs, or drinking alcohol? More direct questions may include, have you tried sniffing glue, smoking weed, or using pills or other drugs? And if and when you smoke or drink or get high, how does it make you feel? Or what does it do for you? In the axis of emotions, eating, and depression, there is a lot of questions about have you been feeling stressed? Do people get on your nerves more than they used to? Are you feeling more bored than usual? What kind of trouble have? Um, have you been trying to gain or lose weight? Have you been feeling down? Have you thought of hurting yourself or someone else? Have you ever tried to hurt yourself? This is the most direct question. Assessment of sexuality is important as well. Questions may include, are you attracted to anyone? Tell me about that person. Here we we have to use gender neutral language. Uh, are you comfortable with your sexual feeling? Are you attracted to guys, girls, both or neither? And have you ever had sexual intercourse? Have you enjoyed it? What kind of steps do you take to protect yourself? And have you ever been worried that you could be pregnant or a father? And have you ever been worried about or had sexual transmitted infection? At the end, the assessment of safety, which is the most important one. Are there a lot of fights at your school? Do you feel safe at school? Is there bullying? Have you been bullied? Do you carry weapons? What kind of things make you mad enough to fight? Does your boyfriend or girlfriend or partner get jealous? Do you ever get into fights with your boyfriends or girlfriends or partner? The question about trauma may include, have you ever seen people in your family or home hurt each other, say mean things or throw things or hit each other? Uh, Many clinics use the patient health questionnaire, BHQ, which is commonly embedded in the electronic medical record. The adolescent version is preferred, however, a clinic may use the adult version. The BHQ-9 screen for anhedonia, depression, sleep, energy, appetite, self-esteem, worthlessness, concentration, psychomotor retardation, hyperactivity, death wishes, and suicidal ideation. It's simple, fast, time efficient, can be used for the triage as a brief screening. It takes 20 to 30 seconds to save a life. The scores of 5, 10, 15, 20 present cut points for the mild, moderate to severe or severe depression. Um, so the majority of primary care clinics screen for suicidal risk through self-report mental health questionnaires like the BHQ. However, self-report measures tend to be oversensitive and underspecific and lack the predictive value. And in this case, it is critical to pay attention to the question number 9, where questioning regarding suicide are addressed, and not on the overall score of the BHQ-9. Of note, if an adolescent answer no to the screening question in HQ9, the provider or nurse should still screen for suicidal risk during the patient interview. So depression scales alone are not enough to assess for suicide. And we recommend a layered approach, and there are many tools to assess for depression and suicide. So become familiar with the ones your team or organization will be planned to use. And if we are using the general or the depression specific scales, it is important to pay attention to a specific suicidal ideation questions in these scales. And if a child or adolescent screen positive for suicidal thinking or behavior on self-reporting questionnaires or in the psychosocial interview, it is critical to follow up about the screen during the visit with adolescents alone to gain more context regarding the severity, the frequency, and the actual intent of any suicidal behavior and thinking. Given the sensitive nature of the material and need for transparency, family influence may filter or challenge the patient's story, as well as threaten the therapeutic partnership. Therefore, completing a one-on-one assessment will facilitate building trust and rapport with the youth and elicit more accurate information. For younger children or adolescents with intellectual disability or communication difficulties, the presence of parents may be necessary to understand what is going on with. Um, the Columbia Suicidal Severity Rating Scale, the CSSRS, is commonly recommended in child and adolescent psychiatry, and it is strategically designed for administration by a range of professionals and paraprofessionals, including teachers, law enforcement, clinic staff, PCPs. The CSSRS uses simple questions and a clinical algorithm to blend collateral input with the clinical presentation to address the ideation type, the intensity, and the important suicidal behaviors involved, such the actual one, the interrupted behavior, and the aborted suicidal behavior, the preparatory suicidal behavior, as well as the associated level of support or services needed for the youth or anyone. The severity and intensity of suicidal ideation, lifetime suicide attempts, and non-suicidal self-injury behavior as measured by the CSSRS were found to predict future suicidal attempts among adolescent and young adult psychiatric emergency department patients. For example, those with preparatory suicidal behavior uh, have 10 times more are 10 times more likely to die by suicide. Those with interrupted suicidal attempts have 3 times more likely are 3 times more likely to die by suicide, and those with aborted suicidal attempts who made an aborted attempt are 2 times likely to have made suicidal attempts in the future. So once types of ideation, of suicidal ideation are determined, few follow-up questions about most severe thoughts, frequency, the duration, the controllability, the deterrence, the reasons for ideation. And there is a specific CSSRS screen with triage points for primary care, which provides a response protocol to yes answers for each question. So we have two versions of the Columbia Suicidal Severity Rating Scale, the full version and the screener. The screener is just screen for wish to die, active thoughts, associated thoughts or methods, some intent and plan, and intent. Those who scores high on 4 or 5 should be followed up with the full version of the CSSRS. So we have talked a lot about the adolescents, but what about children? Is the child capable of communicating or understanding the suicidal ideation? In what stage of development he is or she is? Does he have any poor verbal skills? Is the child telling us everything? Is he shy? Uh, does he or she understand the concept of time? And if not, may not know how frequently thoughts occur. Does he understand the concept of causality? If not, may not understand that a bad emotional state made them feel suicidal. And is the intent to really die in children? So by definition, the suicidal attempt is a combination of suicidal ideation, the suicidal behavior, with an intent between them. So in children, we have to assess the level of hopelessness, the preparation prior to attempt. So is the concept of death understood by the child? Studies showed that in kids age 10 to 12 that are suicidal, they are less likely to believe in death's permanence than the non-suicidal children. So we may have that undeveloped or pathological suicidal cognitive pattern in children who are suicidal as well. Sometimes we cannot the lethality, the judgment of lethality is not well developed in children. So the assess and oversight of guardians will be a key here. So what motivates the child suicidal ideas is important. Are they suicidal just because they want attention, or they just because they want something to change? And younger kids, the suicidal behavior may be a metaphor for impulsivity or reactions for upsetting or mood dysregulation rather than wish to die. In teens, they are becoming more like adults. Uh, so assessing the previous attempt may be useful here, and if the child is glad that he survived from the previous attempt, this may give us a clue that the intent was not to die. So more in verifying the emotional state when the child committing the suicidal behavior. The younger children are more likely to tell an accurate story about what happened if he or she is currently in the same mood as the time of the event. So if they are now happy playing in the clinic, the child may not come up with any clear reports about the suicidal ideation. And if he's still upset, emotional labile, the interview may be more accurate. The observation of play is also useful. So, what do the parents or caregiver have to say? Sometimes the caregivers playing down the suicidal ideation to the social stigma. Sometimes they may have their own psychopathology. So it is important, while it is important to get feedback from the caregivers, it's also important to have the child report for the suicidal ideation as well. So it's also useful to discover or check if there is any deaths in family, any talking about death or suicide. For example, why do not you just kill yourself? Is this kind of talking is usual in the family? So let us now talk about the suicidal assessment, the initial management of depression or psychiatric disorder. If present, is to educate patient and their family about the disorder, about the treatment options, and discuss confidentiality. Then develop a treatment plan with specific goals. establishment of safety plan. We will talk about the safety plan later. And we have to consider bus attempts, highest risk in the 6 months following the last attempt, desire and ideation, plans and preparation. And there is a misconceptions like if a person plans to kill himself, nothing you can do to stop them. False, you can do a lot. Most people who kill themselves never tell anyone they are suicidal. False, most of them do. Asking young people if they are suicidal increases their risk because it puts it in their mind. False, it doesn't. Um, so talking about suicide will save young people's life. Um, the safety plan. When we are tailoring the safety plan, we will thinking about the reasons life, the distracting factors with enjoyable activities, the coping strategies, people that the patient can contact for support, like friends, family, health professionals, doctors, psychologists, counselors. And once a patient expresses current suicidal ideation with a suicidal plan and any intent to carry out the plan, they should be supervised at all times until a complete determination of the risk has been made. Unfortunately, there are no validated criteria available to guide the pediatric provider in assessing level of risk for subsequent suicidal attempt and determining level of care needed. However, psychiatric hospitalization can provide necessary safety, the assessment and the stabilization and initial treatment. Thus, if provokes the important question, when does a provider refer a patient for psychiatric hospitalization, evaluation versus other psychiatric services such as intensive outpatient program, IOP, or partial hospitalization program, the PHP. Within the primary care domain, it is generally agreed that criteria for psychiatric hospitalization include any one of the following. If we have a high lethality attempt with a clear expectation to death, if we have a professional judgment of suicidal risk level where the suicidal risk overweighs risk of inappropriate hospitalization, if we have a patient who possesses limited capacity to follow up through on safety planning, um, continued desire to die, severe hopelessness, ongoing agitation, inability to engage in the safety planning, uh, or insufficient available support system to keep the youth safe, to monitor, follow up, or the inability to restrict access to lethal means. So the treatment considerations, regarding the treatment considerations, so all cases are dynamically different. It is not one size fits all. Clinical algorithm thus taking into account the context and the risk factors in critical to tailoring the so it is critical to tailoring the suicidal prevention and treatment plans. Psychotherapy is also helpful, right? The cognitive behavioral therapy, the dialectical behavioral therapy, the interpersonal therapy. And it is extremely important to learn about and try to contextualize the patient's emotion that triggered the current crisis within the visit. It's important to give the patient advice and offer solutions to decrease the suicidality thinking or behavior, and always prioritizing safety. Um, and regardless of the regardless of the approach, there are five main capillars for the care, which includes the wellness planning, like for example, exercise, diet, sleep hygiene, coping skills, the psychoeducation about suicidal ideation and depression, safety planning, and means reduction, and increasing family and caregiver engagement. Again, to the safety planning, studies have shown that sometimes families actually do not follow the recommendations for means restrictions. The safety plan involves documenting any warning signs that the suicidal ideation is increasing, exploring the coping strategies in patient already uses or in willing to use, identifying people and social setting that might distract the patient, uh, listing the people or patient and phone numbers that the patient can call to ask for help, as well as the professionals and phone numbers that can be called, and agreeing on steps to make the environment safe. The safety plan should be physically given to the patient and family as a therapeutic tool. It can also be a way to document the risk assessment and plan for the medical record as an appendix to the clinical notes. If such a plan is made, it is important to document the response and agreement along the family safety measures for longitudinal follow-up and future prevention conversations. Providers can use these tools for formulate a more comprehensive plan for safety with their adolescent patient and families. And of note, upon completing the plan, the provider should encourage the patient to keep the plan handy at all times or take a digital picture of the plan on their phones for easily accessibility. This is a picture of one of the templates for the safety planning, and we can see that the safety planning is based on the ABC of the behavioralism, the antecedents, the behavior, and what happened, or the consequences, and how consequences can feedback positively or negatively the antecedents. So we have what happened before before the suicidal behavior, the suicidal behavior itself, and what happened after it, so we can work on every step of the process to help the patient modify the suicidal behavior. Suicidal assessment and management are critical skill for nurses and other staff in primary care settings who are at the front line of clinical care for most children and adolescents. And by practicing and implementing the tools and strategies outlined in this presentation, the healthcare team can assess youth in crisis calmly and systematically, convey hope and compassion, implement safety plans, and make appropriate referrals for specialized care as indicated by assessment and risk stratification, addressing prevention at the individual and system levels. Primary care staff can meaningfully contribute to reversing current suicidal trends, saving lives, and improving training around the serious public health issues. Here are some resources. We can see the SAMHSA Safety Bucket Card, the Suicidal Prevention Resources Center, the Self-Injury Outreach and Support, the National Suicidal Prevention Lifeline, the Trevor Project, and transgender, queer, and questioning youth. And here are the references. I would like to thank you. And if there is any question, any notes, you are free to ask or comment.
Thank you, Dr. Smati. We really appreciate today's session. So I would like to open this up to questions from the audience. If you'd like to go ahead and put your question in the chat, that would be fine. If you would like to unmute yourself, you're welcome to do that as well. We have about 10 minutes or so for questions. I did want to ask one question, Dr. Smati. Having worked in healthcare for, let's say, a couple of decades or more, there has been a question by providers to me about safety planning versus safety contracts. And I think that there's still the use of safety contracts out in the healthcare settings. I'm wondering if you could share a bit about why safety planning is really the preferred way of handling youth that have some thoughts about, that are having some suicidal ideation or some thoughts about self-harm versus using safety contracts.
So I think that the safety planning templates are concerned about the individual risk factors and the individual distractors, individual kind of protective factors. So we are working at the microscopic level of suicide rather than the macroscopic level of suicide. The patient if the patient is in the hospital as an inpatient, and he or she is on a 24-hour close observation, it might be helpful in the short run, but the working that done on the individual by himself or by the closest circles around him is the most crucial work. There is a lot of studies showed that hospitalization alone is not enough. The 2 weeks after hospitalization is the most risky 2 weeks regarding suicide. And in the long run, the hospitalization was not proven to alleviate the suicidal risk. On the other hand, self-safety planning, working on the microsystems inside the family, the interpersonal relationships, or with the individual by himself, on himself, was proven to be most effective on the long run, because the change is the changing of the self, not on the environment in regard. So the safety planning is very important because it is addressing the suicidal behavior at the platelet when it happens.
Thank you, Dr. Samadi. Dr. Johnson, I appreciate your comment in here. Would you unmute yourself and share that, please? There are some folks that are on their cell and they can't read the chat.
Yes, I was just saying that safety contracts are like a quote unquote promise to not attempt suicide, whereas with a safety plan, that is more of a guide of what steps to take when someone has suicidal ideations or behavior. So when you're making a safety plan, one of the things that I do with my patients is make sure that all the family members or all the people who are listed as supports on that safety plan have a copy of the safety plan so they know what steps to take, so that when the person who is having the suicidal thoughts or behaviors calls them with their, saying that they're feeling suicidal or that they want to die, that they can talk them through, okay, did you do your coping strategies of X, Y, or Z? Okay, so you've done that and that wasn't helpful. Okay, now we're talking to me. Do we need to call the emergency people? Do I need to come over? Or kind of what steps to take next? So the safety contract is just saying, oh, I promise that I won't commit suicide, and that does not work, because in the moment, usually teenagers especially are impulsive and they end up not remembering or caring about that quote unquote safety contract. Whereas with the safety plan, that is a targeted plan where multiple people are aware of, okay, this is what steps we're going to take when those suicidal thoughts or behaviors come about.
Thank you, Dr. Johnson. I appreciate that. What other questions do we have for our individuals who are on here today? So it looks like, Dr. Samadi, we have Dr. Turner. Is cutting considered a suicidal behavior? And let's ask that one first.
Is cutting considered a suicidal behavior?
Yes.
So it depends on the context of the cutting. So by definition, the suicidal behavior is we have the suicidal behavior like cutting and the intent for killing or ending the life. But if the cutting is just for just to release the tension or to pay attention, so it is depends on the case and on the context of the cutting.
And then Dr. Turner also mentioned, what about the adolescents that say they use it as a coping mechanism for suicidal thoughts? So I guess I'm going to add to this too for Dr. Turner is, as a pediatrician, how do you have that conversation also that where that adolescent says to you, I use it because I'm feeling like I want to kill myself, so I don't, and I cut myself. How do you address that?
So yeah, if there is no intent to kill the self, it is the non-suicidal self-harm behavior. And it is important, but it is not the suicidal behavior. We have the suicidal and non-suicidal behaviors or self-harm behaviors.
So in those situations, would you recommend that that provider refer that patient to a counselor and a therapist to help that individual find a more non-lethal type of way to have a coping mechanism, some other type of coping mechanism when they're feeling that way, Dr. Smati?
Yeah, absolutely. So the first, the cornerstone is psychotherapy, and if the case is moderate or severe, we have to use the medication beside the psychotherapy, working on the coping skills, understanding the context of cutting, and the cognitive pattern of self-harm or suicide is very important. So, in every context, every patient is different. Usually modifying that pattern or the cognitive pattern of suicidal is the key
Terrific. And that's where CPAN
Can
can
I
really
add?
come. Go ahead, Dr. Johnson.
Can I add to that? Yes. So
Sure.
with non-suicidal self-injury, even though it is so sometimes, like Dr. Smiley said, sometimes cutting is is not for the purpose to kill themselves, but it's for some other purpose, such as Dr. Turner mentioned, as a coping mechanism. While non-suicidal self-injury in and of itself is in that moment they're not wanting to attempt suicide. However, non-suicidal self-injury is a risk factor for suicidal behaviors later on down the line, and it's actually one of the higher risk factors. So it is important, but like Dr. Smiley said, the key is that if you have a kid who is using it as a coping mechanism for suicidal thoughts, they need to engage in therapy to develop better coping mechanisms, healthier coping mechanisms, because using cutting as a coping mechanism is very unhealthy, and again increases that risk of suicidal behavior later on down the line.
Thank you, Dr. Johnson. And what I was going to add here is that your CPAN teams that are serving you, if you're a primary care provider, serving patients under age 23, your CPAN team can assist you with obtaining quality therapy services in your patient's area. Depending on the age, there may be also opportunities for video therapy as well. That's available not just for patients who are have their own private insurance, but there are services out there for those who are patients who have Medicaid or are supplemented for their health care through the state of Texas. So I know that that's been a lot of question that we receive is, well, my patient doesn't have insurance. What's available for them? We need to get them into counseling. Typically what I have heard and what Dr. Samadi and Dr. Johnson have said here is that counseling is that primary way of treating situations such as what Dr. Turner has here. What other questions do we have? We have just a couple minutes. Go ahead, Dr. Johnson.
Can I add that, yes, that because, and the reason for that is because just because there is suicidal thoughts or non-suicidal self-injury, that does not mean automatically, like some people equate that to mean, oh, this child is depressed. And that does not necessarily mean that it's depression or anything like that in context with it. So even though they may have these thoughts or may have these behaviors, don't automatically assume, oh, well, they're depressed and they need to be put on an antidepressant. That doesn't always equate to one another. So that's another reason why medications aren't the end all be all for this. Yes, if there is a co-occurring mental health condition that can be treated with medications, if that is present, yes, use medications. But again, the main importance is the therapy and developing healthier coping skills.
So Dr. Johnson, Dr. Samadi, the other co-occurring diagnoses, we're talking anxiety, possibly trauma too?
Yes, it can be any of them, or it can be none of them. Some kids don't even have any kind of mental health condition, and they just have thoughts, in the moment of, something, they just had a bad day and it was bad enough to where they said that they were suicidal, but they're not depressed or anxious or anything. So yes, those other conditions can occur in these contexts, but that doesn't mean they have to be present. There's also situations where there's nothing that's present as well.
Great, thank you very much. And that's why reaching out to your CPAN team can be such an important part of your practice. Reaching out, talking to our psychiatrists, as well as those individuals who answer the phones for our hubs, are therapists. They're trained therapists. They may be LPCs, they may be LCSWs, but you'll have a specialist in mental health that can with you and work with your clinic to support these patients. Dr. Samadi, I want to thank you for your support today, your great teaching. Dr. Johnson, for your backup on this. I am going to go ahead and put the disclosures back up for folks so that they have that available. Give me just a moment. I want to make sure I grab the right slide deck here.
Thank you so much. Thank you.
Thank you. And if y'all just give me a second, I've got too many screens going at one time here, and we'll get those disclosures back up here in just a moment. All right. It's coming, I promise. All right, there you go. So this is the QR code if you are a physician, a nurse practitioner, or a physician's assistant. That's that one right there. If you are a nurse, this is yours right here. They are different evaluations. The requirements are different. Again, this is the QR code for nurses. And this is the one for physicians, nurse practitioners, and physician's assistants. Thank you for being with us today. Next month on the 27th of March, we will be presenting non-suicidal self-injury, the SOARS model. Dr. Westers from Children's and UT Southwestern will be presenting on that. He is actually one of the professors who has developed that assessment tool, the SOARS model. If you have not been to the session on non-suicidal self-injury, it's a great adjunct to today's session from Dr. Smati. We hope that you will join us on the 27th of March. That is a Monday, and we appreciate your attendance today. Have a great day and a great rest of your week.
Thank you so much. Thank you. Have a great day.